Dr. Malhotra is a world-renowned cardiologist, author and advocate for healthcare reform, who has dedicated his career to improving health outcomes and challenging the status quo in medical field. Today, Dr. Malhotra will be addressing the critical topic of health before profit. In his talk, he will dig into the pressing issues surrounding the influence of economic interests in healthcare practices and policies. He will share his insights on how we can shift our focus towards patient-centered care, emphasizing the importance of nutrition, lifestyle changes, and evidence-based medicine in preventing and treating chronic diseases. And Dr. Malhotra's commitment to transparency and integrity in healthcare has made him a leading voice in the global health community. His work has not only sparked important conversations, but has also driven significant change in how we approach health and wellness. His talk promises to be both inspiring and thought-provoking, offering us new perspectives and new strategies to prioritize health over profit in our healthcare systems. Please join me in giving a warm welcome to Dr. Aseem Malhotra.
Thank you, Felix, and thank you for coming today to hear me speak. It's really a pleasure for me to be back in the Netherlands for first time to give a talk in 6 years. Last time I was here was pre-pandemic and discussing the Pioppy diet, my book, which did very well, and I will mention it a little bit in my talk today. So I like to start my talks with quotes, and ancient wisdom teaches us that evil is rooted in ignorance. But what's worse than ignorance? The illusion of knowledge. About 18 months ago, I slowly and reluctantly came to the conclusion that with the rollout of the COVID vaccines and the mandates and the coercion, we were likely dealing with the greatest corporate crime, medical mistake, and damage to population health that we will face or witness in our lifetime. It wasn't easy for me to come to that conclusion. One would wonder, despite that, me making that statement and other people in this movement also appreciating this, that this still hasn't resonated with most of the population yet. And the reason for that is, we have to start from this place, not just about COVID vaccines. I think about many things we do in life, many of our perceptions about health, is that the main barriers to the truth are primarily psychological. The first barrier to the truth, and I think we can all appreciate this with what happened during the pandemic, is the phenomenon of fear. When you're in a state of fear, it inhibits our ability to engage in critical thinking. And when the pandemic began, when the World Health Organization announced, obviously, lockdowns, etc., there was a grossly exaggerated fear of COVID. I'm not saying that COVID wasn't a problem. I have people that I know that suffered very badly from COVID. I know elderly, vulnerable people that died. But the overall narrative made people think that, and this is from a survey in the United States, at one stage early on, they felt that if they got COVID, there was a 50% chance, 1 in 2 chance they would be hospitalized with it. When in fact, the information we had at that time was very clearly telling us it was only about 1%. So it's a huge gap there. And you can't engage in critical thinking. And the other aspect of fear is that when you're in a state of fear, you're more likely to be compliant. Okay, with authority. Those numbers, I'm a numbers person. As a doctor, I try and take complex information as a cardiologist to explain to my patients about risks and benefits. You have to understand numbers, and you have to be able to communicate those numbers in the way that the patient understands. Without understanding the numbers involved, the public are vulnerable to exploitation of their hopes and fears by political and commercial interests. And that's exactly what happened. The second phenomenon, psychological phenomenon, which we're all capable of, vulnerable to, is something called willful blindness. So this is when human beings turned a blind eye to the truth in order to feel safe, avoid conflict, reduce anxiety, and also to protect prestige and fragile egos. And this can happen in a circumstance where a spouse turns a blind eye to the affair of their partner. Okay? We look at historical examples, institutional willful blindness, Harvey Weinstein in Hollywood, or Hollywood and Harvey Weinstein, the Catholic Church and child molestation. Okay? So these are clear examples. So this is something that we can all be vulnerable to. So I think we need to start from that position to understand why what is the most important barrier to the truth. It's not intellectual, it's primarily psychological. Around a year ago, I was invited to go on a podcast, which some of you may be aware of, but Joe Rogan podcast, which is the most listened to podcast in the world, and combined, he gets more listeners than CNN and Fox News combined. And one of the most interesting things that came out of that podcast, other than me talking about the vaccine, which I will come on to, definitely, but this isn't the crux of my talk yet, what seemed to be the most popular on YouTube was actually the discussion, here we go, let's see if it's working, excellent, around statins. Now, I'm a cardiologist, and I've started my kind of advocacy and campaigning primarily to shift the understanding of the causes of heart disease. And this is still a big issue because statins are probably one of the most prescribed, if not the most prescribed drug in the world. It's estimated they are prescribed to 1 billion people. So I'm going to talk about how we can understand and take the lessons of statins and apply it to actually many things in medicine to then give us a better understanding of what we need to do moving forward so we can actually improve people's health. We are emotional beings, and we resonate most. A lot of what shapes our lives are the stories we tell ourselves. And one of the ways of conveying interesting information to the public and to patients are case studies. So I'm going to start with one of the most interesting patient case studies that I would say probably in my whole career. So Tony Royal, I know you can't necessarily read all this, but I'll walk you through it. So Tony Royal was an international airline pilot, okay? In his early 50s, runs marathons, follows a standard low-fat dietary advice, right? He's a good boy. He listens to the government, but he's slowly putting on a bit more weight, and he goes for his health check. 55-year-old guy, and he basically finds, this is in 2014, he's got an increased waist circumference, his body mass index puts him in the overweight category, he's not obese, 28. He has a cholesterol check done, not great, not the worst, and he ultimately, in December 2014, he gets off a flight, having flown to South Africa and back, thankfully not on the flight, with chest pain, and he goes to his general practitioner, and he has an ECG done, and there are some changes. And long story short, he's diagnosed with a heart attack, a minor heart attack, thankfully, has an angiogram done, and it shows that he's got a complete, almost 99% occlusion in one of his arteries, so he gets a stent put in. So he's had a heart attack, he's had a stent, he's got some what we call bystander disease, one of his other vessels has a blockage of 57%, and he gets put on the usual cocktail of medications, as we do, right? When patients come in, we give them lots of medications which are evidence-based to help reduce the risk of further heart attacks. And he gets told the same standard advice. What else should I do? Oh yeah, follow a low-fat diet, keep exercising. And he's thinking, okay, fine. So he does all of this. He's been given a high-dose statin, 2 blood thinners, aspirin, etc. And about a year later, right, he goes back. He doesn't feel a lot better, but about a year later, he starts feeling not very well. He's got muscle fatigue, he's got erectile dysfunction, he's got some memory disturbance, and he's now noticing that he's having poor recovery from exercise. He then himself, now what's interesting about Tony, he's an unusual patient. Tony can no longer fly because he's had a heart attack, right? But his previous job was being a maths and physics teacher. So he's quite clever, and he's very, very good with numbers. And he starts looking at all the medications he's taking and realizes that that the medications he's taking, the benefits are actually quite marginal. But he also starts thinking that he's getting side effects from statins. So without talking to his doctor, he decides he's going to stop his beta blocker that he's on and his statin. So he stops it. And within 3 months, within weeks, first thing that happens is within weeks, he notices a very marked improvement in all his symptoms. Suddenly, his energy's better, his erectile dysfunction is gone, his mental clarity is there, and he attributes it to the statin, just within weeks of stopping the statin. And he's been miserable for a few months. Simultaneously, he'd come across some of my work and reading about diet stuff, and he decided that he was going to experiment and actually change his diet and actually follow a low-carb diet. So he removes cakes, biscuits, starchy carbs, juice from his diet, increases intake of non-starchy vegetables, oily fish, eggs, full-fat dairy, all that kind of stuff. Doesn't do anything different in terms of exercise. And 3 months later, he's lost 3 stone in weight, okay, almost 20 kilograms. His waist circumference has gone from 38 inches to 30 inches. Cholesterol profile is a bit better. And he feels like a new person. He's also simultaneously, without speaking to his doctor, now stopped all his medications. This is a guy who's had a heart attack. He's got a stent, all right? And he's feeling great. And this is where he comes to see me for the first time privately. And I'm sitting in the office, and he's telling me a story. And I'm like, okay, this is interesting. This is great. He said, but Dr. Malhotra, and he's a smart guy, there was one thing I'm not quite sure about whether I should be doing now. And this is why I wanted to speak to you. He said, I'm thinking of doing Ironman competition next year. I don't say I was literally aghast, but I was like fascinated. And I said, okay, all right. Do you think I'm at risk? And I said, well, you probably would increase your risk a little bit, but you're now, doing really well. You're in great shape. But I said, let's have a conversation. Personally, I would think you should go back on aspirin and maybe consider a low-dose statin. But it's your choice. He goes away and he calls me up a couple of weeks later and he says, listen, I've decided that I'm going to stick with my plan of no medications. All right? Now, this was in 2016. I'll come back to Tony Royal later on. Just remember this, like what's happened to this guy. We're almost 10 years later. I'll come back to him later on. But what this case highlights, actually, is for me the most important slide of my talk. So please feel free to take a picture of this. Mark Twain said, truth often lies in simplicity. This is an elegant analytical framework for teaching and practicing medicine. It's called the evidence-based medicine triad. All right? Very controversial at the moment. 1996, published in the BMJ, Professor David Sackett. Now, why is this so good? Why do I think this? I think this triad isn't just about how we should best manage patients. I actually think we could also call it the real democracy triad. What do we want to do as doctors or practitioners? We want to improve patient outcomes. That's in the middle. What does that mean? Managing risks, treating illness, and relieving suffering. Okay? How do we achieve that? 3 components are crucial. We use our individual clinical expertise, our knowledge, our experience, our clinical intuition. The best available evidence, whether it's on a drug, whether it's a surgery, whether it's a lifestyle intervention, whether it's ordering investigation. But last but not least, David Sackett stresses the most important, the final part, taking into consideration individual patient preferences and values. That's called informed consent. Because if you offer or you prescribe something to a patient that they don't want, it's not going to work. They're not going to be compliant. Even if you take the ethics side apart. It doesn't take a rocket scientist to figure out that if anything is wrong with one or several of these components, at best, you will get suboptimal patient outcomes, and at worst, you're going to do harm. If a doctor is making clinical decisions on biased and corrupted information, that's what's going to happen. And unfortunately, evidence-based medicine has become an illusion. Evidence-based medicine has been hijacked by powerful commercial vested interests, and we have a pandemic. This is even before the recent so-called pandemic, right? We have a pandemic of misinformed doctors and misinformed and unwittingly harmed patients. based upon a number of factors, which I'll come on to. But what else did David Sackett say? And this is something that is not a narrative, that is something that is known amongst the public, and this is really important. He said, half of what you learn in medical school will turn out to be either dead wrong or outdated within 5 years of your graduation. The trouble is nobody can tell you which half, so you have to learn on your own. And why is that? Medicine is not an exact science. Hold on, but didn't Fauci say trust the science? Medicine is not an exact science, it never has been. Okay? It's an applied science. It uses scientific principles, but it's just as much an art as it is a science. It's constantly evolving. It's a science of human beings, right? We are not fixed. We're not like, it's not engineering. It's not maths or chemistry. So this is really important for people to appreciate and acknowledge. So what are those factors behind the pandemic of misinformed doctors and misinformed patients? Okay, so this is relevant because we have all this healthcare crisis around the world because of lack of an efficient system, okay, based upon a number of factors. Biased funding of research. Research that's funded because it's likely to be profitable, not beneficial for patients. Biased reporting in medical journals. Biased reporting in the media. Biased patient pamphlets. Commercial conflicts of interest. What am I pointing at here? Clickers. Oh, here we go. Commercial conflicts of interest, defensive medicine, and last but not least, medical curricula that fail to teach doctors how to understand and then communicate health statistics. This is really important, one. And I'll explain that in a second. Now, how prevalent is this problem? I've talked about these concepts of biased funding of research. Somebody I consider to be the Stephen Hawking of medicine, I think I can make a good case for that, is Professor John Ioannidis, professor of medicine in Stanford. Okay? He's the most cited medical researcher in the world. He's a medical genius. He's a statistician as well. He has very high scientific integrity. And in 2017, and this is a great paper to read, and you can look it up online. It's free, open access, and very easy to read. He writes about the fact that 20 to 50% of all healthcare activity in the United States brings no benefit to the patient, is wasteful or harmful. Of almost $4.3 trillion they spend in the US. That is extraordinary. And he says that basically this is because of overuse of medications, underuse of simpler, safer options, avoidable adverse events, waste, and missed opportunities to give the right patient the right treatment at the right time. So what's the reason? Why is this perpetuating itself? Why is it there? Why does it even exist? Why have we got these problems? And he highlights it with a number of factors. Much published research is not reliable, offers no benefit to patients, or is not useful to decision makers. Think about that. In fact, in 2006, he published a paper which was called Why Most Published Research Findings Are False. Okay? So that's a big issue. And in fact, the problem of an over-medicated society, one estimate from Peter Gersher, the co-founder of the Cochrane Collaboration, pre-pandemic, he said the third most common cause of death globally after heart disease and cancer, prescribed medications. What your doctor prescribes for you. In large part because of avoidable side effects. Why? I'm sure you're already figuring it out. Because invariably, the results of drug trials that doctors use to make decisions for patients will grossly exaggerate the benefits and safety of those drugs. Okay? The second aspect to this, what I've just said, why are we not changing the system? Because most doctors, healthcare professionals, are not aware of it. They don't know about this. Medical knowledge is under commercial control, but most doctors don't know that. Therefore, the system continues to cause harm. They then lack, and this is a problem in medical training as well, okay? Doctors then lack the necessary skills to evaluate the reliability and the usefulness of medical science. And then last but not least, patients and families lack relevant, accurate medical evidence and skill guidance at the time of medical decision making. What are the factors, one of the most important factors, why most published research findings are false? He says this: the greater the financial and other interests and prejudices in a scientific field, the less likely the research findings are to be true. What is the most lucrative product in the last few years, and one of the most lucrative products in the history of medicine? The COVID mRNA vaccine has made Pfizer $100 billion. We'll talk about how good those products are. We'll get there. With data, with hard data. Okay, let's come back to heart disease again. So we've had this 1 billion people apparently prescribe statins, okay? It's supposed to be the miracle cure for heart disease. Nobel Prize winners at the end of the 90s who discovered the LDL receptor said that because of statins, we will probably see the eradication of heart disease, right? We had in 2011, William Roberts, the editor of the American Journal of Cardiology, wrote in an article called "It's the Cholesterol, Stupid." And what did he write? This eminent cardiologist in America? He said, you can be an obese, diabetic, sedentary smoker, but as long as your cholesterol is low enough, you will never develop heart disease. Yeah, you're laughing, right? Crazy. So, but actually, and I'll come on to the statin stuff, we haven't seen really much of a decline with statins in heart disease, and I'll show you that data in a second. So what's really at the root of heart disease? And this is something that hasn't really been challenged. And this was a study that was done in diabetes care that gave estimates based upon risk factors of what was really at the root of heart disease. And it basically said that if in young adults, preventing insulin resistance, right, would prevent 42% of heart attacks. And then after the next most important determinant of heart disease is systolic hypertension, high blood pressure. Then it was low HDL cholesterol. Then it was body mass index. LDL cholesterol came lower down. And in their conclusions, they said, insulin resistance is likely the most important single cause of heart disease, coronary artery disease. A better understanding of its pathogenesis, its cause, and how it might be prevented or cured could have a profound impact on coronary artery disease. This is 2011. But many of you here know insulin resistance is essentially primarily driven by lifestyle, and you can resolve it with lifestyle, but of course there's no market for this message. So that's why most people don't know about it. Okay, I'm going to throw something else in there just to muddy the waters a little bit. So the conventional wisdom has been for many years that LDL cholesterol, which is a so-called bad cholesterol, is something we should primarily focus on, you know, in population health, in public health, cardiologists, lipid specialists. This is the most important thing we need to lower to prevent heart disease. But I started looking at this literature. You know, I started looking at this probably about 10, 12 years ago. And going back to, because I was a cardiologist saying, hold on a minute, we've got all these patients on statins, there are side effects going on, we're not really combating heart disease in the way we thought we would, and you know, there's an starting to increase prevalence in heart disease. So I thought, have we got this wrong? And one of the interesting findings of the Framingham study, which sanctified LDL cholesterol as being the bogeyman, is that once you hit 50, as cholesterol dropped, this is the original, one of the original studies that influenced guidelines and changed medical practice. When cholesterol started to drop, mortality increased. So that's a bit odd. That wasn't really ever discussed. So myself and a number of international scientists decided to do a systematic review to look at the evidence, up-to-date evidence, looking at whether, first of all, is LDL cholesterol, bad cholesterol, associated with heart disease in older people? Okay? We used to use the word 60 of being elderly, but I know 60 is like the new 40, right? Yeah. But we looked at older people, right, over 60. What did we find? This was published in the BMJ. First of all, no association with heart disease at all. But the other interesting finding we found is that there was an inverse correlation with LDL cholesterol and all-cause mortality. In other words, statistically, the higher LDL, the less likely you were to die. What's the explanation for that? Well, one of the roles of cholesterol is actually in the immune system. Older people are vulnerable to dying from infections, gastrointestinal infections, pneumonia. It probably had some protective effect. We also know that low cholesterol is associated with cancer as well, which probably is through immune mechanism. So these are the likely explanations, but at the very least, it at least informs the medical literature that maybe we've got it a bit wrong about obsessing about lowering LDL cholesterol. So this was press released. And I remember writing an article in the Telegraph newspaper around it at the time, and I spoke about it on Sky News. And one of the things I wrote about is just after this was published, I felt, okay, it's published now, it's peer-reviewed, we've talked about it. A patient came to see me in clinic in the NHS. This older lady walked through the door, and she looked white as a ghost. She was really scared. She looked really terrified. And she was 62, and she walked in. I said, "What's wrong?" She said, "My GP has told me my cholesterol is very high." I said, "Congratulations." I said, "You're probably going to live longer." And I sat down with her and I explained all of this, and she walked out a very happy lady, but I was just being honest. Okay, so that's one study, but then separately, a Danish study also looked now, we just looked at the older people, sorry. A Danish study in 2021, I think, if I'm not wrong, 2020, sorry. In the BMJ, they actually looked at all ages, okay, over a 10-year period in Denmark, 100,000 people, aged 20 over to 100, to look at the association of LDL cholesterol in all these people to and its association with heart disease and all-cause mortality, though, specifically. And what did they find? Now, before I tell you what they found, guidelines at the moment around the world, and this is really important to understand, will give you a red mark or will alert your GP and then lead to fear in yourself and other people and patients, right, who are given the same thing. If your LDL is above 3 millimoles per liter, it's high and you're at risk of heart disease and you must get it down. This observational study actually found the optimal level for LDL cholesterol for longevity, as in living as long as possible, was actually between 3.4 and 3.9. So that means actually people... Now, I've got a confession to make. I recently had my cholesterol checked, and it's around 2.93. I need to get it up. So I'm doing everything I can to increase my cholesterol, okay? Because I want to live a bit longer. Okay. Now, something else. When I do stuff, I want to cover all the bases. I've looked at this cholesterol issue in so much detail. I have to cover every single base. No stone is left unturned. There is a mantra, again, that has existed for many years within cardiology. You go to conferences, it's almost become a gospel truth, right? As you lower LDL cholesterol, you get less heart attack, strokes, and death, okay, with drugs or diet. Okay, so we've talked about the association is a little bit sketchy, but the other way of looking at this hypothesis to see whether it's true is that if there is a genuine causality with cholesterol and heart disease in the conventional thinking, then lowering it should reduce heart attacks, right? So myself and two other cardiologists did a systematic review in BMJ evidence-based medicine, and we took, and this is still interesting, we took industry-sponsored trials on many different cholesterol-lowering modalities, the new PCSK9 inhibitors, statins, etc. We put all these studies together. There was, I think there was 30-odd studies, right? All the totality of evidence to see, was there a clear relationship with lowering LDL cholesterol and preventing heart attacks and strokes, which is conventional mantra in cardiology. In fact, cardiologists will say, right, almost in a religious way, for every 1 millimole lowering in LDL cholesterol, you get a 20% risk reduction in heart attacks, right? It's repeated constantly. And what did we find? There was no such correlation. Hold on, I'll show you. There was no correlation at all. Pardon my language, it's complete and total bullshit. And in fact, because of that, I'm very clear, and I've been clear in the public, and I've been clear with my patients, lowering cholesterol is not in any way, shape, or form part of my approach to managing heart disease at all, right? Rita Redberg, who is a well-known cardiologist in America, editor of JAMA Internal Medicine, has even publicly said that we should probably even stop measuring cholesterol. Because what happens is it drives unnecessary fear, and it's an excuse to put people on statins that they don't need, right? So this is the level that we're at. This is what we're up against. Okay, we're going to go back in time now a little bit of drama. But before we go there, okay, this is probably the most maybe challenging slide of my talk, but most of you, I'm sure, can get this. But this is a statistical slide, okay? But it's very straightforward, I promise you. Misleading health statistics, all right? There are many ways of presenting a benefit. You can use something called relative risk, or you can use absolute risk reduction, also known as numbers needed to treat, NNT. So if you communicate relative risks, it can lead lay people and doctors to overestimate the benefit of a treatment. All right? So let me give you an example. If you take the randomized control trials, these are considered the highest quality level of evidence, all right, to look at the benefits of a statin in people with type 2 diabetes who have a high risk of heart disease and stroke, etc. And if you look at that data, in type 2 diabetics, you treat them with atorvastatin for 10 milligrams over 4 years. Okay, so in one group you're giving atorvastatin 10 milligrams, the other group's getting the dummy pill, and they're effectively clones of each other to try and see whether there's a benefit. The relative risk reduction, the way it's reported, the way it's communicated, is a 48% reduced risk in stroke over a 4-year period. So let me just give you that, put that in a context of a consultation. Patient comes in, sees a doctor, they're type 2 diabetic. Oh, you're type 2 diabetic. Take this, I'm going to prescribe you this statin. You're almost 50% less likely to have a stroke over the next 4 years. Oh, wow. That sounds pretty good, doesn't it? 48% reduction? That sounds quite dramatic, doesn't it? Quite beneficial. What does it actually mean? Right? What does it actually mean? If you look at that data, the trial data. So in the 1,000 people who did not take atorvastatin, just took a dummy pill, were just going on along as normal, over a 4-year period, those 1,000 people with type 2 diabetes, 28 of them had a stroke with no additional treatment. And the people that took a statin, 15 of them had a stroke over 1,000. Okay? So you've prevented 13 people having a stroke. Right? 13 over 28 times 100 is 48%. Yes, you get it? So 48% less likely. But in reality, you've treated 1,000 people with a pill and you've prevented 13 strokes. 1.3%. 1.3% is 1 in 77. Yes? That's numbers you need to treat. You need to treat 77 people. By the way, there's a big caveat here. Right? What is that caveat? This is still data this is drug industry sponsored data that has not been independently verified. So this is if we trust, so I do this all the time in my practice, right? I'm a practicing cardiologist. When I have discussions with patients, you have to put in what we call uncertainties in the evidence. And when a patient is asking me a question about a statin, I say, if you believe this data, which by the way has not been independently verified and the drug industry is there to make money, and you don't get side effects, there's a 1 in whatever 77 chance that it's going to prevent you having a stroke, etc. Now that sounds very different, and actually at that sort of level, when you do studies to look at whether patients take a statin or whatever, any of the drug, most of them would choose not to take the pill. And most of the people prescribed statins around the world are in the lower risk category. They're in this 1 in 100 so-called benefit. But they're not told this, okay? And of course we'll come on to the barriers to, you can understand why that is information that the drug company wouldn't really want being part of the mainstream. And then medical journals, unfortunately, have made the issue worse because what they've done is they've reported the benefits of pills in relative risk terms, but the harm in absolute risk terms. Okay? And actually, there was a sample done in 3 of the major medical journals. A third of the articles published in The Lancet, the BMJ, and JAMA between 2004 and 2006 use this mismatch framing. This is not science. This is not ethical. This is marketing. These are our major medical journals that we as doctors, as medical students, were taught or conditioned to believe was biblical truth. This is good science. This is ethical, right? We go around with our proud sort of discussions in our, in the coffee room and with the patients, and we have this great scientific knowledge. It's bullshit. It is, honestly. It's unbelievable bullshit. Now, the issue about absolute risk reduction, okay? It was interesting. Yesterday I did an interview for Black Box, all right? And I was in this discussion, and I didn't know what was coming up. And this guy, and it's good, journalists, I'm not afraid to be challenged by anybody. In fact, whenever I do an interview, sometimes they say, oh, doctor, we give you a question? No, don't give me the questions beforehand, right? If I don't know something, I'll say I don't know, but I'm not, I'd rather just, be organic and let's speak. And I said, you can get anyone, anywhere, to challenge me in anything I'm saying. We should have the discussion. I did not know he was going to put up a video of some guy called Debunk the Funk, all right, who was challenging some of the things I've said on the COVID vaccines, and he brought up the issue of relative and absolute risk reduction. And it was unbelievable. I saw this video, and this guy was saying, Dr. Malhotra is misinforming people. The way to explain any benefit is relative risk reduction. And I thought, this is interesting. So he said to me, Dr. Malhotra, what do you think about this? Is your opinion? He's challenging your opinion. I said, actually, it's not my opinion. World Health Organization Bulletin 2009, from the world most eminent researcher on health and risk literacy, Gerd Gigerenzer, Max Planck Institute in Berlin. And this is in a book, you can look this up, still there online. It is an ethical imperative that every doctor and patient understand the difference between absolute and relative risk to protect patients from unnecessary anxiety and manipulation. In other words, if you've got that information and doctors are not conveying absolute risk reduction to patients, for me, it is unethical. They are unwittingly practicing unethical medicine. Okay, we're going on a little bit of a journey which goes forward and backwards. So I'm going to take you back in time a little bit. 2010, 2013, around that time, just as I was becoming a consultant, I was a junior doctor, I was looking into all this issue of obesity and the data on nutrition and cholesterol, etc. I published my first, well, I started publishing medical journals before that, but probably the most publicized article I wrote at the time was this one in the BMJ in October 2013 called Saturated Fat is Not the Major Issue. And I put the jigsaw together in 800 words, all right, as a commentary, which was peer-reviewed, and I basically said, the evidence doesn't suggest really that saturated fat from things like butter and cheese and et cetera, causes heart disease. But actually, we do know that saturated fat does raise LDL cholesterol. So I said, well, if that's the case, then does that mean LDL doesn't cause heart disease or it's not a major factor? So I had to add that in. But if cholesterol is not a major issue for heart disease, how do statins work? Because statins do have some benefit. And I said, well, actually, one of the ways statins have a benefit is they have anti-inflammatory and anti-clotting properties. So it isn't from lowering cholesterol. There is a small benefit from statins, but that's probably the mechanism, okay? And I also said we should be using low-carb diets for managing metabolic syndrome, which is the biggest cluster of risk factors for heart disease. And I also said the sugar industry is a big culprit here. So in one article, I'd taken down nutrition dogma on saturated fat. I had really exposed the overprescription of statins to millions of people and said that the sugar industry. So obviously, I didn't think about it in this way, but clearly I'm now targeting many industries. Now, if this was just a publication in the BMJ, it's one thing. Something else happens when it gets press released, okay? The BMJ press release an article, it goes to 6,000 journalists around the world, they take it as a big deal. Suddenly, it's front page of 3 British newspapers. By the way, I'm still a junior, I've completed my training, but I'm still a junior doctor at this point, right? Front page of 3 British newspapers, international news, CNN International, Fox News Chicago. It was fine, because I was already, I was an activist. I wanted to get this information out. But of course, once you then put your head above the parapet, you're exposed, you're going to get the backlash. The first thing that happened, within a day of publishing this, I was very pleased. I mean, a lot of people were very happy, because the way the newspapers framed it, one of the front page articles, I think the Times newspaper said, butter is back, right? So people obviously like butter. Right? So there was all of that going on. But this is where it's interesting, and I'm going to come on to this. The reason I'm mentioning this is also there's something recently happened in Holland, which you may be aware of, with a publication in the BMJ Public Health involving the Princess Maxima Institute as well. So there's a reason I'm telling you this story as well, which is relevant to what's going on now. I was working at a hospital as an interventional cardiology fellow. I was the top sort of trainee, and I was doing all the cases and the operations, etc. And doing well and thriving. I'd only started working there for a few weeks. And, my hospital was named in these articles, Croydon University Hospital, everywhere. And, the secretaries, the nurses, they were so proud, so happy. Oh my God, Aseem, our names. And within 24 hours, I get a phone call from the secretary of the medical director of the hospital. All right? And she says, I can't remember his name. So-and-so wants to meet you. And I just, you have an intuition. I don't think this is going to be good, but I say to the secretaries, he said, oh no, I'm sure he's really happy. He wants to congratulate you for what you've done. So I go up to his office, this guy, I've never met him before, doesn't even shake my hand, opens the door. He's literally red in the face and almost frothing at the mouth. Okay? Come in, sit down. So I sit down. And he says, I've been speaking to the General Medical Council about you. Do you know your duties as a doctor? And about this article. What's the meaning of this article? I said, well, it's, peer-reviewed, blah, blah. I talked to this. And he goes, are you saying that our cardiac nurses are going to tell our cardiac patients to eat butter instead of margarine? And I said, yes. We had a polite discussion. And at the end of it, to be fair, and I kept calm, he said, listen, I hope that in 10 or 15 years from now, I can sit opposite my grandchildren and tell them that I met the man that busted the myth of saturated fat and heart disease, okay? Now, that's where the conversation ended. But ultimately what happened is things started to evolve, and simultaneously, I'll get onto the rest of that story. So that was a little bit of a warning shot to me in that hospital. At the same issue of the BMJ piece I'd written on saturated fat, John Abramson from Harvard and colleagues actually had simultaneously published an analysis of whether or not statins would benefit people at low risk of heart disease. And they had concluded from the numbers needed to treat that if you had a less than 20% risk of heart disease in the next 10 years, there's no mortality benefit. You're not going to live any longer, okay? And if you have a 10% risk or whatever, low risk of heart disease, there's at best a 1 in 140 chance of the statin preventing a minor heart attack and a non-disabling stroke. So basically no prevention in real serious illness. And this was published, and this was not refuted, but both of us, interestingly, simultaneously, this is where things really got a bit out of control. We had cited a study, a real-world study, okay, in the United States, that suggested that 1 in 5 of all patients taking statins, remember this figure, 20%, 1 in 5 of all patients taking statins suffered unacceptable side effects, in particular muscle fatigue, muscle pain, etc. All right? And we'd both said this, and some of the press had covered this fact. Now, this is around October 2013. So this now started to evolve, and there was more discussion going on. By the way, simultaneously, the journal, of course, had many attacks coming in. We had the nutrition scientists, we had the statin pushers, we had the sugar industry, and they were all writing letters, and I had to respond to them. So this is what happens when you've got to be prepared for this, right? Suggesting there were errors in my article, or I wasn't looking at the evidence. So I did all of that, and I did it well. But Professor Sir Rory Collins, probably considered, I would say, one of the most influential, powerful man in medicine in the world, professor at Oxford University, epidemiologist, okay, who runs a clinical trial service unit, he got his knighthood from his work on statins. He immediately contacted the editor of the BMJ, Fiona Godley. And I remember meeting Fiona afterwards and saying, Rory Collins has come in. But he basically said, just wrote a letter straight away, these articles need to be retracted. Now, of course, that's a big deal. For a medical journal to retract an article, for an individual who's written a paper, when some people call for retraction, it can be stressful. And if a retraction happens, it's potentially career-ending. And he said that both me and Abramson had committed errors in our paper, and specifically, he alluding to the fact that we'd exaggerated the side effects issue. And because of that exaggeration, people are going to stop statins and people are going to die. All right? Fiona Godley said, I'm not going to retract it, right? But she was a good editor and said, listen, at the very least, we can offer you a page to do a criticism in the journal, and we will publish that. For some reason, Collins didn't want to go down that route. I don't know why. Okay? He just kept saying, retract, retract, retract. She stood firm. Then suddenly there is, in March 2014, a few months later, it becomes a big headline story, BBC News, The Guardian, front page of The Guardian. Collins says that the errors that we've committed are so dangerous, it's worse than what Andrew Wakefield did with the link with the MMR and autism. So suddenly now I'm having to, BMJ's involved, I'm having to react to this, and, said that there needs to be an independent inquiry, et cetera, et cetera. So the BMJ are now put under pressure. Before I tell you what happens next, this is what Professor Sir Rory Collins said in The Guardian. Remember this comment, okay? When he called for retraction. There are only 1 or 2 well-documented side effects of statins. Myopathy and muscle weakness occurred in 1 in 10,000 people, he said. So think about this. We're saying 1 in 5. He's saying 1 in 10,000, and a small increased risk of diabetes. Sorry. I will fast forward. There was a few key points happen after that. So this is March 2014. Then, suddenly the BMJ's put on a lot of pressure. I'm actually in New York. I wasn't warned about this, and I get sent a press release, and I was like, oh my God, this is going to be all over the news, which it was. The BMJ has decided that we had made a slight error in one of our references that needed a correction, and they put that in. But they were going to send our articles, myself and John Abramson from Harvard's articles, for an independent review, all right? And we were essentially on trial for 2 months for retraction. And 2 months went by, and I was asked to submit evidence and what was going on. And eventually, and this then story was repeated again, the panelists from around the world actually came back unanimously, 6-0 in our favor, no reason for retraction. Okay? So we got through that, and that became a great, it was a good win. For me, though, it was interesting. I think part of this was to try and scare us off. But of course, for me, I suddenly thought, hold on a minute. Something's not right here. He's really gone overboard, and I just kept going. And I didn't hesitate, and I was publishing in other articles, and this was about informed consent. I kept publishing and getting stuff into the news, and I'm sure it was really pissing off Rory Collins. So the Lancet, that have published most of the articles on statins, then held a press conference, and they said that, there's something else that was missing, from all of this. What was never reported in any of the news stories is that Rory Collins and his department have received hundreds of millions of pounds in research funding from people that manufacture statins. That was never mentioned, and I thought, this is very odd. Why is this not being mentioned? Okay, there's a huge conflict of interest there, in my opinion. So then we carried on this battle. I kept pushing the cholesterol narrative. In the mainstream media, I was still considered, someone that a voice that needed to get, out there. So I kept going. I said informed consent. I got other people involved, other doctors coming involved. Said, yeah, this is really important. Let's keep pushing this forward. The Lancet then do a press conference, 2016. Said we're going to now we've got, because of all this controversy of statins, which we think is harmful. Rory Collins and his team are now going to reanalyze their own data to see whether there is a side effect issue, right? The problem is this. The drug companies, they will sponsor these scientists to do their analyses, okay? And then we are supposed to just completely trust their analyses, which is never independently verified, all right? And this is what was going on. Then, so this goes out in the news, there's another back and forth, and they come out and they say, okay, there may be 1% of patients get some kind of side effect, but it's not really very serious, and it's reversible. And they wanted to stop the story there. About a week later, I'm in America at a conference, Mind, Body, Green, I think it was, and I get a phone call from an investigative journalist from the Sunday Times. And he said, Aseem, you'll never believe what I found. And this is from the actual article. And before this got published, just to let you know, the University of Oxford got involved and they wanted to shut this story down. They didn't want this story going out because, of course, they had to go to the University of Oxford, right? One of the most prestigious medical institutions in the world, yeah? Okay, so this is from the article. Remember Rory Collins, the statin side effects are rare, 1 in 10,000, all right? So this is from it. Sorry, this clicker's not working very well. Okay, I'll read it out to you because it's not easy to read. So Rory Collins, this is from the Times. So Rory Collins, a professor of medicine and epidemiology at Oxford University, led a review into statins published in The Lancet earlier this month, which found not more than 1 in 50 people will suffer side effects. All right? Collins, who believes millions more Britons could benefit by taking a statin, is also co-inventor of a test that indicates susceptibility and muscle pain from them. The test, branded as Statin Smart, is sold online for $99 on a website in the US that claims 29% of statin users will suffer muscle pain, weakness, or cramps. The marketing material also claims that 58% of patients on statins stop taking them within a year, mostly because of side effects. Okay? Royalties from this can be used for university research, but Collins and his co-inventors have waived personal fees. Anyway, Boston Heart Diagnostics, that was pushing this so-called test out and manufactured it, interestingly, they stood by their claims saying that a US task force on statin safety had said that randomized control trials, such as those used in the Lancet study led by Collins, had major limitations because patients with statin intolerant side effects were often excluded. Right? This is a lesson most doctors also don't know this. When these randomized control trials are done, and this happened early on, they did a run-in phase where for several weeks they put people on statins, these are people who are volunteering, by the way, to be part of a trial, and then they remove those patients who have got side effects or are non-compliant, and then they start the study, and then you're reporting on the people that didn't get the side effects in the first few weeks. This is medical science, people. This is what's happening in medicine, all right? Now, interestingly, obviously a bit baffling, isn't it? And I was in America, and I was actually with a scientist who works for Pharma, and I told him this story, and you know what he said to me? He said, "This is standard, Aseem, making money from both sides." All right? And actually, the Freedom of Information request was done. This never hit the news. And John Unger Thomas, the journalist, shared this with me. And basically, now it's obviously a lot less compared to how much they've made from, the institute being funded with £200 million or whatever. But basically, his department, from the sale of this particular device, looking for statin side effects susceptibility, they received over £300,000, okay? And, you can draw your own conclusions from that. All right, we'll finish the statin discussion soon. So one of the things that many people ask and they wonder about when you all talk about life extension, and when I give this talk to GPs, they're absolutely shocked. This is published in the BMJ. How much longer will you live if you take a statin? If you look at the statistics differently, okay, randomized trials, industry-sponsored, of course, not independently verified. If you're at high risk of a heart attack, the high-risk people, okay, and you take a statin religiously for 5 years based upon the trial data, people would expect to add maybe several years to the life extension. The actual data tells us it adds just over 4 days. How many GPs are telling their patients that? You take this statin religiously and you don't get side effects? I can add 4 days to your life expectancy over a 5-year period. To be fair, when I said this to Joe Rogan, he made a really important point. He says, well, they could be a great 4 days. This is another problem. There's another issue. The illusion of protection. So it isn't just about patients not being fully informed, it's also they think, and I've seen this with patients, their cholesterol is lowered, right? It means they can go and eat what they like, right? But think about the net effect of this. You're increasing insulin resistance. So the net effect in the current management of heart disease with statins in many ways is negative. Because not only are people not being fully informed, they're also thinking that it allows them they're safe if they... So this is another problem, and it's probably another driver. And in fact, there was a study in the United States that showed when they compared like for like, people taking statins versus people that didn't, like for like, ended up actually fatter compared to... So there is some evidence to suggest this could be a problem. Briefly on the COVID pandemic, in terms of COVID itself, March 2020, I had very quickly looked at the data coming from Italy and China, and with everything I knew in relation to excess body fat and metabolic health, had concluded that actually it was quite clear that the people who are most vulnerable to COVID are also the same people who are vulnerable to heart disease, etc., from having excess body fat. But the good news, I thought, was that you can actually manage and even reverse or improve some of these risk factors dramatically in 21 days. That's why the Piopi diet did so well. It featured on Doctors Van Morgan, 28 days, etc. They showed examples. One person had their type 2 diabetes put into remission just within a month, right? These dietary changes are very powerful. So I talked about this on British media, and I did some publications. And, this is really a very simple way, the most important way, in my view, to manage heart disease, which doesn't involve lots of expensive tests, is for every doctor and patient to just know what metabolic health is. All right, which is linked to excess body fat and insulin resistance. And most of these tests are very easy to measure, and they're cheap, okay? And you basically want to have your blood pressure within normal range. You want your HbA1c to be less than 5.7%. Waist circumference should be normal. Blood triglycerides should be less than 1.7. HDL should be greater than 1 millimole. And the problem we've got, and this is something that I highlighted in an article in European Scientist when it came to COVID, is that only one in eight Americans actually have optimal metabolic health, and only 1 in 4 aged up to the age of 40 are in the same category. So this is a big problem, right? This is the major issue. The good news is, again, there is no real pill to manage this other than looking at individual risk factors and blood pressure pills, etc. The best way to manage this, or the most important way, is through lifestyle changes. And it isn't just about, obviously, heart disease. If you look at insulin resistance, there's a lot of good evidence now emerging that it's probably the main driver of Alzheimer's disease. Alzheimer's disease has been described as type 3 diabetes. Probably the second most important risk factor for cancer after smoking. So, so many issues, so many problems we can probably solve in population health just by focusing on metabolic health. Just repetition and reinforcement. When I wrote my piece in the BMJ about saturated fat, then things evolved and people came out of the woodwork and people started looking at the data again and thinking, actually, there's a lot of truth here. And I thought this time, let me get two other cardiologists involved as well, who are eminent, Rita Redberg, Pascal May, both editors of medical journals. Because, of course, it's easier to attack one person. It's less easy to attack a few people saying the same thing. And we published this piece just to reinforce that saturated fat does not clog the arteries. And actually, heart disease should be understood as a chronic inflammatory process that can be effectively reduced by lifestyle interventions. And this kind of sums it up. I did this graphic myself. This was published in the British Journal of Sports Medicine, the BMJ. And again, it got into the news. But really, insulin resistance is also responsible for about 50% of hypertension. Many of my patients, I'm sure practitioners here also have that experience, that can actually come off blood pressure pills and normalize their blood pressure, even if they've had blood pressure for years, from just combating insulin resistance with lifestyle, which essentially is a low refined carbohydrate, real food diet, moderate exercise, and of course stress reduction, which I will come on to as well, because that's very interesting, and smoking cessation. So if you do that rapidly in terms of changes, it's not just about your long-term risk. There is data to show that short-term risk of heart attack also improves massively. Okay, let's just get on to the vaccine discussion. So many of you may know, but I'll repeat it again. In January 2021, all right, I had 2 doses of the Pfizer vaccine. Most of my work is informed by my patient contacts. I've never come across up to that stage of vaccine injury. Didn't even know what that was. I knew from the literature that vaccine side effects are extremely rare from the published literature. But comparing it to other interventions we do in medicine, I still believe this to be true. Traditional vaccines are probably amongst the safest, all right, compared to a lot of what we do in medicine. And I took 2 doses of the Pfizer vaccine in 2021, in part because I thought it may protect my patients, even though I knew my risk from COVID was low. The other thing, and some of you here may be able to appreciate this, I had an emotional influence from my father. My father, who was a retired GP, vice president of the BMA, he had an exaggerated fear about me getting COVID and dying. And part of that fear exaggeration was because we lost my mum just a few years earlier. I lost my older brother, when I was young. For him, I was everything and the last person, surviving member of his family. And we had even arguments. I haven't really publicized this, but I remember even at the vaccine center, we got him to a row, and he started scolding me like I was a disobedient child, right, for not taking this. And I said, fine, I'll have it. So I went and took the vaccine. I was skeptical about efficacy, but I didn't really expect it to be. I couldn't conceive of there being any serious harm at all. April of that year. And at the beginning, that also went on TV at the very beginning, February 2021, to help tackle vaccine hesitancy amongst people from ethnic minority groups, right, who are high risk. At the beginning, it's really important to remember the timescales here. We were just told, if you remember, this was only going to be offered to high-risk people and elderly. There was no discussion of low-risk people. There was no discussion of mandates, etc. So at that stage, I went on TV and I said, listen, and I never got invited back, by the way, to talk about this on Good Morning Britain, because I don't think the producer was expecting me to say, well, actually, I understand why people are vaccine hesitant. Look at the history of fraud of the drug industry over the years, right? So I said that first. But then I said, but with everything I know, I can't see a big issue because vaccines are amongst the safest. And I left it like that. And but then over time, I started to get a bit suspicious, but I thought, okay, this is Big Pharma trying to make money. They started to expand and roll out to more healthier people. And then I went for a walk with a friend of mine who I consider one of the brightest cardiologists I've ever met. Very, very bright guy. He was one of my juniors that worked with me. He can, tear apart research papers for fun. He's Oxford, PhD, brilliant mind, very high integrity. cardiologist as well. And we went for a walk in April 2021. He said, Aseem, I've got to tell you something. I said, what is it? He said, I've not taken the vaccine. I said, oh, really? I said, why is that? He said, something troubles me that I noticed in the supplementary appendix of Pfizer's clinical trial in the New England Journal of Medicine. He said there were 4 cardiac arrests in the vaccine group and only 1 in the placebo. Now, it's a small numbers, but he said, listen, if this is a signal, we could have a major problem, and I'm going to wait and see. And I said, fine. And I kept it in the back of my mind. I didn't think much about it. I was still very much thinking this is not likely to be true, right? So I didn't pay much attention to it, but I remember him telling me that. July the 26th, 2021, 5 p.m., I was just come back from the gym. It was a hot day in London. My father lived in Manchester. He had a couple of missed calls, which he wouldn't normally do. We spoke to each other several times a day. We were very close about anything and everything. And I called him up and I said, what's up? And he said, Aseem, I've got chest discomfort. And as you know, any good doctor knows, 80% of your diagnosis comes from the history. So I said to him, but before I obviously went into that discussion, something I also got to confess, both me and my father, terrible hypochondriacs, okay? Maybe this is a doctor thing, right, where we can be good objectively. He was a GP, I'm a cardiologist. Anything coming, I've got a strange rash or a spot, oh my God, I call him up and said, no, it's nothing, it's fine, okay, thank you. Vice versa, all right? But of course, history is key. And I said, what explain it to me. He said, I've got a tightness in my chest. I said, is it going anywhere else? It's going to both my arms. I've had it for about 30 minutes. I said, how bad? 6 out of 10. I said, Dad, and I wanted to keep him calm. I said, Dad, it's probably nothing, but you need to call an ambulance. Because you need an ECG. You need an ECG. And he said, only because of that reason. I said, you need an ECG. And he goes, I'm going to call the neighbors who are doctors. They were consultants in the local hospital, and I think they were home. He said, what are they going to do? You need an ECG. He said, they'll need ECG, even if it's normal. You may need to be admitted. And I said, okay, fine. And he was reluctant to call an ambulance. I don't know why. He was very reluctant. And I'll never forget. So I went to take a shower. And, listen, Indian people from Indian origin, they can be very melodramatic. Okay? Very melodramatic. And the last thing he said to me before I went on to have a shower to get ready to change and go up to Manchester to see him and obviously think he was going to be admitted to hospital and stay in, he said, Aseem, my will is in the drawer. I got into the shower and I remember just thinking to myself, because, I've trained as an interventional cardiologist, I've managed cardiac arrests, there's all this thing, and you always think, if this is a heart attack, in the first, early on, this is a time where you can have an arrhythmia, right? And I just said, no, but I don't know why, it just came into my head. Got out of the shower, called him back, no answer. Kept calling. Eventually, what had happened was he'd called 2 of his neighbors who had gone round. One was a consultant hematologist, and she answered the phone, and she was hysterical, and said, your father's had a cardiac arrest, we're doing CPR on him. I then got into kind of, okay, I've got to stay calm. I said, tell me what happened. She said, well, we went to see him. My husband, who's an anesthetist, actually was calling the ambulance because he was sitting there a bit uncomfortable, and as he's calling the ambulance, he just keeled over. And I just said, listen, that he's lucky. I said, you've got a witness cardiac arrest, you've got 2 doctors doing CPR, the ambulance will be here in 8 minutes. I've published stuff on ambulance delays. So I know ambulances' response time is 8 minutes. So I'm on the phone, we're waiting, 10 minutes go by, no ambulance. 20 minutes, no ambulance, right? 30 minutes, ambulance comes. They FaceTime me, okay? And they put the cardiac monitor on. It's asystole, it's a flat line, there's nothing to shock, he's gone. And I just said, just stop, right? Obviously, I'm distraught. I'm trying to figure out lots of different things. I got on the train, went up to see him. And what emerged over the next few weeks, there were 2 things that emerged. The first thing was I got a phone call. This became a big news story. My dad was considered probably, for many people, the chief, the main campaigner for the last 3 decades in the UK on promoting and saving and protecting National Health Service values. All right? So there was Guardian, everything. Lots of people were talking about it. And I thought, why is there an ambulance delayed by 30 minutes? I was actually quite angry. How has this happened? And the deputy chief nurse of NHS England called me up, and she was crying. She knew my dad, what had happened, and she said to me, Aseem, I've got to tell you that for the last 2 months, across the whole country, the Department of Health and the government had deliberately withheld information from the public and from doctors that ambulance calls were not making anywhere close to being in time for cardiac arrest and heart attacks, and people were dying. And I said, because for me, if we had known that, we wouldn't have called an ambulance. The local hospital was 5 to 10 minutes away. He would have got there, he probably would have still had a cardiac arrest, but he would have been shocked out of it, and he would still be fine. So of course, then I exposed that. I'm not going to keep quiet. But before I exposed it, and this is relevant to a cultural problem, which is something we need to all try and appreciate and then combat. I messaged one of a cardiologist who I consider one of the good guys, a training program director in London, right? Well-known, I won't name him, very well-known cardiologist, one of the most published cardiologists in the world, actually. And he knew me. And I said, Prof, just to let you know, this is going to come out in the news soon. I worked with an investigative journalist in the I newspaper. This is going to come out in the news soon. And I'm going to expose this. And he was very friendly with me, but he said, listen, I wouldn't do that if I were you, Aseem. You're only going to make yourself enemies. And I said, what about our duty to patients? There wasn't really much of a response. So there's a cultural problem here. Anyway, I ended up exposing it, and obviously that became a news story, and became BBC News and all that kind of thing. The other aspect to it is that why did my dad have a cardiac arrest? He was a super fit guy, he was very active. I mean, I consider myself extremely fit, but during lockdowns when we were going for walks, he was out walking me, right? In his early 70s. I knew his cardiac status. He had high blood pressure, but he had a coronary calcium score done a few years earlier. He had, if anything, a very mild furring. His post-mortem showed 2 critical narrowings in his arteries. 2 of his arteries, severe now. I thought, this is odd. There was no actual heart attack. There was just a reduction in blood supply. Heart muscle was strong. He'd had an arrhythmia and died. I said, this doesn't make sense. I can't figure this out. And this is my area of expertise. A few months passed by. I'm now in Sweden giving a talk on metabolic health, and I get a phone call from a Times journalist. This is the first bit of information that comes to me. Dr. Malhotra, we've got an unexplained 25% increase in heart attacks in hospitals in Scotland. What do you think's going on? Now, at the time, I had predicted, because of my work, that because of lockdown stress and because of people's diets getting worse, we probably would see an uptick in heart attacks. So I said, that's probably the main reason. The journalist herself, interestingly, she threw at me. She said, well, what about the vaccine? I thought, this is a bit odd. Why is she asking me this question? I said, listen, I would be a bad scientist to exclude any possibility. Let's keep an eye on it. That's all I said. And the Times ran a headline based upon my interview saying, lockdown stress and poor diet blamed for increase in risk in heart attacks. Okay, so that was October 2021. Then 2 things happened for me which straight away changed everything and my trajectory on all of this, on this journey. The first was a publication in Circulation, which a lot of you may know is a very high-impact cardiology journal. Stephen Gundry, who interestingly I met last week for the first time, is a cardiologist, cardiothoracic surgeon in America, and he's all into the lifestyle stuff, and he uses something called a pulse score. A pulse score is a blood test that measures markers of inflammation in the blood that correlate and predict heart attack risk in the next 5 years. Now, he does it regularly, and his patients are obsessed with getting this checked. So this happened by accident. He told me this last week. I didn't know the full story, actually. He said he was checking their pulse. They were getting their pulse score checked. And suddenly, he noticed there was a huge increase in risk. And he said, what's going on here? And he spoke to his colleagues, and he said, this has all happened after the vaccine. So they did a more intense study, and they basically found, in what he published in Circulation, this abstract, that the baseline risk in these patients went from 11% risk of heart attack in 5 years to 25% within 8 weeks of having the mRNA vaccines, Pfizer and Moderna. Now, for me, first of all, I thought, if this is even partially true, the vaccine is accelerating heart disease, so I linked it back to my dad, who had a cardiac arrest 6 months after his vaccine. But of course, it's just one bit of data, but I thought, let's look at, see what, but then I remember the Times journalist, I'm thinking, okay, we've got real world stuff going on, we've got plausible mechanism now. And then within 2 weeks of this, I got a phone call from a cardiologist at a very prestigious institution in the UK who was very upset, and he knew me and he trusted me. He said a group of researchers in our department, cardiologists, have accidentally found from different modalities, from imaging, cardiac imaging, some specialized MRI that looks at what we call vulnerable plaques in the arteries, plaques that are more likely to cause heart attacks. They'd accidentally found that there was inflammation going on in the heart arteries, which is there in the vaccinated, but is not there in the unvaccinated. Okay? But the problem was this. The lead researcher sat his whole team down. I think there was probably about 15 or 20 of them. And he said, we're not going to explore these findings any further because it may affect our funding from Big Pharma. I couldn't then, my conscience wouldn't allow me to stay quiet. And of course, I was nervous about this because I had also swallowed the narrative, but I knew what I was about to say and what that impact that could have, but I couldn't stay quiet about it. And I then went on GB News, and that became a big story. It got lots of views, etc. And I was very measured. I said, listen, I've got these 3 bits of information. I didn't name the institutional whistleblower to protect him. But I said, I'm going to ask, and this is also, and interestingly, around this time, they started to introduce mandates. So I started then campaigning saying, we should not have mandates. There's a big problem going on here. And I think it needs to be investigated. And I think that's all I said. I didn't even say stop the vaccine, but the chief medical officer, the vaccine committees, they need to look into this. I then, again, behind the scenes, I got an email from the Royal College of Physicians. Okay, I was a fellow there. And they said, Dr. Malhotra, we've had a number of anonymous complaints from other fellows that you are spreading anti-vax disinformation. And I thought, how crazy. I've had the vaccine. I've even gone on TV to reassure people. And now I'm saying there may be a cardiac issue. We should look at it. That's it. This was obviously stressful. I was still mourning the loss of my dad. I was, spending time with my family. And I basically decided I had to respond to this, etc. And eventually they left me with a warning. Okay? And they left me with a warning to be careful of what I'm saying. I then realized I was dealing with something really, really big. And whenever I've done my advocacy work, I've done it from a place where I felt that I have done enough research myself, enough critical analysis, and usually I've done it through publications in medical journals. If I do it through that process, I also feel I'm protecting myself, I'm being more accurate with information, right? And then I can go hard on something that I think is important to get out. So I then decided to publish in the Journal of Insulin Resistance, which I chose that journal partly because it was open access. 2, it doesn't take money from pharma. And 3, it was the only journal that allowed me to write 10,000 words because I needed to walk people through the process and then also explain how we got here. But on the and a lot of you know this stuff already, but I'm not going to go through lots of data on the vaccine, but I think the most important bits of information you need to know are this. What are the benefits of the vaccines and what are the harms on the best available evidence, okay? And the UK government was the only government in the world, I think, to be transparent with this information, which was interesting. At the beginning of last year, they published real-world data on the benefits of the COVID vaccine. All right? Remember, numbers needed to harm, numbers needed to treat. So based upon this information, 2 doses of the COVID vaccine, Pfizer, Moderna, whatever else, if you were over 70, and by the way, this is not corrected for socioeconomic status, this is just for age, so this is likely an exaggerated benefit. In general, unvaccinated people, on average, who were sicker. We know the mortality was higher, more likely to die from COVID, so this is an exaggerated benefit, but just to give you some numbers that you can understand. If you were over 70, you needed to vaccinate 2,500 people to prevent 1 person being hospitalized with COVID. All right? If you were 50 years old, 18,700. If you were 20 to 29, 162,000. I am not aware of any pharmacological product in the history of medicine that has such poor efficacy. If it wasn't such a serious issue, it would be laughable. This is the benefits that we know from now real-world data of this vaccine. What about the harms? On best available evidence, reanalysis, Pfizer and Moderna's randomized controlled trials published in the journal Vaccine, peer-reviewed by some of the world's most eminent scientists, Santa Greenland, considered one of the world's top epidemiologists, Peter Doshi, associate editor of the BMJ, Joseph Freeman, data scientist who I know is the first author. What did they find from the original trials that led to the approval of the vaccine? You are more likely to suffer serious harm, disability, life-changing event, all right, or hospitalization from taking the vaccine than you were to be hospitalized with COVID. From the very beginning, at a rate of 1 in 800 at 2 months, the short term, at least 1 in 800. Think about that for a second, right? In my view now, it's very clear. This product should never be injected into a single human being in the first place. There was a survey done, not high quality, okay? Survey done in the United States to try and ask people, remember, 80% diagnosis of history. Did people feel that either themselves, a family member, or someone had suffered serious harm or died from the vaccine in the US? And this was published in BMC Medicine, which is a well-known journal. It was retracted, by the way. I didn't make this clear later on. Not because of errors, because the editor, does this sound familiar? The editor got put under pressure. Okay? But what did they say in the survey? They said estimates from the survey indicate that through the first year of the COVID-19 vaccination program, there may be as many, this is in the US alone, by the way, 278,000 vaccine-induced fatalities and up to 1 million severe adverse events. Now, if this is even close to the truth, it suggests the serious adverse event rate may be 1 in 300, and the death rate may be as high as 1 in 1,000. And if that's the case, okay, that means if you vaccinate 3 billion people, you're going to kill 3 million, all right? And I think that the evidence is pointing closer and closer to that figure, unfortunately, all right? We'll come back to how this has all happened. So I'm a root cause guy, so people need to understand the bigger picture here so we can move forward productively, all right? What we're trying to advocate for, even before the pandemic, and I got the medical Royal Colleges involved in this, is about informed consent, like the basics of evidence-based medicine, ethical evidence-based medical practice. That means decision-making. So I wrote up in a medical journal with the chair of the medical Royal Colleges, former chair, Tony Rawls' story. And the reality is this, if patients are fully informed, they actually tend to choose less treatment, they have less operations, right? And they feel more empowered, and the outcomes are not any worse. So you're improving efficiency in the system already, all right? So it's better for the whole healthcare system, but it's also ethical. And we wrote up Tony Rawls' story about the fact that he said this is unusual, but he'd made an informed decision. He knew the numbers he needed to treat. He stopped all his pills. And now, many years to 2022, this is Tony Royal, breaking his own records in ultramarathons, okay? Yeah. He's going to be doing World Ironman next year, and all his metabolic parameters are great. In fact, we did some more imaging on his heart. There's actually suggestion of maybe possible reversal of one of his arteries, the moderate blockage he has, but very, very stable. And then this got press release, and of course, I'm going to get more attacks, which are going to come, which I will come on to in a minute. But this became front page of the Daily Express, ditch pills to beat heart disease, all right, based upon this. And the Daily Mail, ditch the statins and eat your way back into good health, experts controversially claim, right? Now, obviously ongoing battle here, keep publicizing this. I'm undermining statins apparently, I'm a statin denier. I'm a statin denier. And this is not, listen, I'm not trying to over or exaggerate what the lifestyle approach can do. But these anecdotes, these stories are fascinating. And this patient emailed me, and she came to see me, and I told her to go on POP diet, low carb, Mediterranean, etc., and reduce stress. And she sent me this, and I thought it was extraordinary. The same ultrasonographer did this, right? And she said, I followed your guidelines and reduced a blockage in my carotid artery to below 50%. It was 60 to 75% before that, within a couple of years. This is quite extraordinary stuff, right? Because in cardiology, most cardiologists, most doctors do not believe or even think it's possible to reverse the narrowings, to reduce the blockage to actually reverse heart disease. And of course, as you know, this got, obviously when someone, a stranger on Twitter, I think, sent me this message from Schiphol Airport that POP diet had overtaken Stephen Hawking's book. I was like, wow, this is clearly having a lot of impact, right? But as you know, it stayed 6 weeks. And I think your Nutrition Foundation or one of your dietetic associations, they came out and started criticizing us, saying we're saying that carbohydrates are essential for health and that this diet has no fiber. It was completely false. In fact, our dietary plan has more than the amount of fiber that's recommended. So then it got knocked off the top, but that's fine. I'm not that bothered about that. We got the message out there. And of course, it got all these endorsements. Now, the reason I'm telling you this is I know that we are going against conventional medical wisdom, medical practice. We're going against food industry, etc. And there is a safety in numbers issue. And because of safety in numbers and because of the people I come across, I try and get them involved in the sense that they've either benefited or they want to support this, and it's much more difficult, again, to attack. For example, the mayor of Manchester talked about the POP diet, and he was a former Secretary of State for Health, Andy Burnham, and maybe tipped eventually to become the future leader of the Labour Party. And he said, this book has the power to make millions of people healthier and happier. We had the former personal physician to the Queen of England, Sir Richard Thompson, saying that every medical students should read this book. So this was great. I was very proud of it, and I thought, okay, there would be some protection here. But no, not necessarily. The deputy leader of the Labour Party, I didn't know this guy. We made a film called The Big Fat Fix, and we premiered it in British Parliament. And he saw that, and it was even mentioned in Parliament by one of the MPs who challenged 100 MPs in Parliament to go on the Pioppi, because a lot of MPs are overweight as well, to go on the Pioppi diet. So this was actually, even in parliamentary notes, it's still there. And he called me and he said, listen, I've struggled with my weight for so long, and I've tried every different diet under the sun. I wanted to wait, but I just want to tell you, in the last 1 year from following your diet plan, I feel great. I've lost 100 pounds. Okay? This was the deputy leader of the Labour Party. All right? So all that was going on, and then we went on, this was covered in the documentary behind the book was based upon, was in BBC World News, etc. But there's something that we need to learn. So what are the lessons here from me talking about the diet plan, being a lead campaigner? I know this talk isn't about sugar. I helped bring about the sugary drinks tax as well. And I followed a kind of formula. Some of it was intuitive, some of it was experience, and some of it actually came from the literature. Simon Chapman is considered the lead campaigner in Australia who helped bring about tobacco control. All right? And he wrote this article in one of the public health journals, his reflections on a 38-year career in public health advocacy, 10 pieces of advice to early career researchers and advocates. And he says that public media attention on an issue is often more powerful than private advocacy in bringing out policy change. Sunlight is a very powerful disinfectant for malodorous health policy. That resonated with me because one of my inspirations is Mahatma Gandhi, who almost single-handedly got the British colonialists out of India. But how did he do it? Through a non-violent movement. He believed, as I do, most people are intrinsically good, most people want the truth, and most people hate injustice. So what do? Make the injustice visible, right? And this is what it's all about. We want to optimize our own and our patients and public health, and we know that people are being misled. So the counter to this is make that injustice visible, and people, through their goodness, eventually will turn, and something will be done. But one of the other lessons from his public health advocacy is this, and you have to be prepared for this. As soon as your work threatens an industry or an ideological cabal, you will be attacked, sometimes unrelentingly and viciously. Okay? And not long after Tom Watson and everything else was doing well with the Pioppi diet, Public Health England, who is a government body, supposed to be independent, they were calling chief executives of hospitals in different places to try and deplatform me, not allow me to speak about Pioppi diet. All right? And I thought, okay, well, you want to play those sorts of games? Okay, fair enough. Let's expose you for that. The Sunday Times, I had good relationship with lots of journalists, and I explained this to a guy called John Thomas, who's a Sunday Times journalist. And then and not only that, there's something else they did. When the book came out, I had the mayor of Manchester, I had the chair of the medical colleges, two really important people who were endorsing the book. They called them up and they basically said, you being associated with Malhotra is going to be an embarrassment to you. This is going against our guidelines on healthy eating. And they wanted them to publicly dissociate themselves from me and the book. All right? Now, they could have capitulated, and I know maybe they felt there was a pressure, but they didn't, and they stood their ground. And Tom Watson, who was a deputy leader of the Labour Party, also stood his ground. And he said to me, it seems extraordinary that a government agency responsible for helping us get healthy has tried to close down a respected cardiologist who just wants people to make people well. If they disagree with him, debate with him, but don't silence him. Their response said that its dietary guidelines, which Watson ignored to lose weight, is supported by the best scientific evidence. Now, guess what? Those guidelines, that Eat Well guideline in the UK and many parts of the world, right? There was a publication in the BMJ that looked at who were the stakeholders involved in making up the healthy eating plate, which, by the way, has a lot of starch in there. Also has cakes, biscuits, and sugar and chocolates in the corner with a slogan underneath, eat less often and in small amounts. But it's on the plate. It's in hospitals, right? And when you look at who made up those guidelines, Kellogg's, Coca-Cola, McDonald's. Yeah, this is apparently supported by the best scientific evidence. Yeah, right, sure. Okay, a big problem. But then, 2019, this is the front page of the Mail on Sunday, all right? Myself and two other people, a doctor and nutrition scientist, are basically accused of being statin deniers, our deadly propaganda of the statin deniers, all right? This is pre-pandemic. And the editor, Barney Kalman, of the health editor, said, there is a special place in hell for doctors who claim statins don't work. So there's also, I've never said statins don't work. I'm talking about informed consent. This is how they frame things. Oh, all right? And what was interesting in this article is they quoted the Secretary of State for Health at the time, Matt Hancock. I don't know if you're familiar with that name. Yeah? I know, so interesting, I met Matt a week earlier when I gave a talk in Parliament, and I embarrassed the British Dietetic Association, and I met Matt, and he took my book, and later on he lost 2 stone on the thing. Matt is quoted in this saying, there is no place in the NHS for people like this. So I thought, this is strange. So I messaged Matt. I sent him a message. I said, Matt, what's going on here? And he goes, Aseem, I didn't realize they were referring to you. This is now in a court case, by the way. I did not get involved in the defamation case because actually it was just not long after my mum had died, and I didn't want to get involved. So there is something going on at the moment. 2 of those people are taking Mail on Sunday to court. It's now with the judge, waiting for a judgment for defamation, right? So there's stuff still going on here. But because of this, I was working in the NHS. I'm very passionate about the NHS. And a month after this article, I got a text message. Right? From the person that is involved in the employment side saying my services were no longer required. And because of that, and I've tried to get back in the NHS, this has been a big issue, a big problem. So this stuff does unfortunately work. I've carried on obviously working privately, but this is the kind of stuff you have to deal with. And then more recently, as you know, I knew that my publication, normally every single publication I've been involved with has hit the mainstream media. Only because I write if there's something important to say and everybody needs to hear it, I will do everything I can to get this in the mainstream. When I published at the end of 2022, October, in the Journal of Insulin Resistance, I said the vaccine needs to be suspended, the harms may likely outweigh the benefits, etc. And I worked with a journalist exclusively for 2 months who wanted the story, and I knew if this goes into the mainstream media, right? If this goes into the mainstream media, I know that it's game over. Right? If it gets into the mainstream media, it's done. There will be a pause, etc. I know how these things work because I've been involved in these campaigns before. Last minute, he pulled out, and I was distraught. I was honestly distraught because I'd put 9 months into this peer-reviewed paper. It was strong, and I knew it needed to get mainstream impact. I was distraught. But then I remembered the words of Martin Luther King, and he said this: if you can't fly, you drive. If you can't drive, you run. If you can't run, you walk. If you can't walk, you crawl. Just keep moving forward. And I thought outside the box, and I managed to get it into some international news. All right, so I got stuff moving a little bit. And then in January, about 3 months later, I get a phone call from the BBC. And the journalist saying, well, we've now got this excess deaths issue, and the chief medical officer last week said that the excess deaths that are happening in the UK might be because people stopped taking their statins during the pandemic. And I thought, for fuck's sake. Sorry, pardon. I thought, really? I didn't say that to the journalist. I said, okay, which obviously is not true. And he said, well, Dr. Malhotra, nice, our guideline body is now coming out suggesting maybe more people would benefit from taking statins. Basically, everybody over the age of 50. And I said, he said, what do you think about that? He was just testing me. And I said, well, yeah, statins have a role to play, high risk, but low risk, whatever. And I said, lifestyle, talking about lifestyle. Oh, that sounds good. We need this discussion about lifestyle. Could you come on? And actually, one of our guests is cancelled. Can you come on in like 15 minutes? I never normally take my phone in the gym with me. I put it in the locker. For some reason, I kept it with me that day, all right? I'm in the gym. I'm sweaty. I shaved in like 2 weeks. And I'm like, I've got 15 minutes to get into my... And you know what I'm thinking right now? I'm thinking, this is an opportunity to talk about the excess deaths and the vaccine. So I run up to my flat quickly, get the tripod out, start the discussion, and slowly, I think I've seen this, slowly start bringing this discussion about excess deaths and maybe linked to the vaccine. It goes absolutely crazy and viral on Twitter, 25 million views. So remember, dissemination of the truth, make the injustice visible. I'm quite happy that we've got the discussion going. But of course, after that, one of the other things, I'm expecting there to be a backlash. I had also, when I published my paper, what's important also is to engage politicians. I was actually invited by an MP who was trying to be an advocate for vaccine injured to give a talk in Parliament, and they wanted me to talk about my findings. And I knew this was a great opportunity, and about 20 MPs were supposed to come. And about 15 minutes before I'm supposed to give the talk in Parliament, the Prime Minister, Liz Truss, resigns. And there's chaos, right? Only 3 MPs turned up. But I also remember Shami Chakrabarti, the director of Liberty, human rights lawyer, very famous. She's a friend of mine. I remember sitting with her one day she said, when you've got an issue, Aseem, all you need is one journalist and one politician, right, to get it out there. I go to this talk. There was an MP there that I'd never met before who was sitting there listening to me very intently. His name was Andrew Bridgen, all right? And at the end of my talk, he looked at me, and he went thumbs up, and he basically said, I'm going to call you. And then he went away, and of course he started speaking in Parliament, and he asked me to help him write his first speech in Parliament, and I went to witness it. I didn't think that he would verbatim literally read out everything I had written, but anyway, it was good. And so this was all in the background. The BBC story comes on, and then within 24 hours of the BBC stuff on Twitter, I'm basically now main story, headline story in The Guardian, BBC criticized for letting cardiologists hijack interview with false COVID jab claim, all right? And in the article, it was just a real hatchet job, but I almost found it, funny in a way, because I had a friend call me. She was actually she's a Scottish cabin crew, and she was a bit upset and said, Aseem, they're saying in the article that you're not even a cardiologist. This is the extent. I thought they've really overreached here. It was so ridiculous, right, this hatchet job. And I gave a response. And then the Times also did this, basically this article as well a couple of days later. Andrew Bridgen, the MP who was groomed by gangs of anti-vaxxers. So just in case so no confusion for you here, apparently the guy standing on the stage in front of you today is the leader of a grooming gang of anti-vaxxers, all right? But why was this good? What else did Gandhi say? First they ignore you, then they laugh at you, then they fight you, then you win. This is a sign of progress. Okay, let's just take a step back again, all right? The million-dollar question, can heart disease be reversed? And I'm trying to put everything together here, because actually what's extraordinary, what I found, for at least a couple of decades, there has been good quality, reasonable research to suggest that you can reverse heart disease. Mount Abu Heart trial, done in India, by a cardiologist, he took people with moderate to severe blockages in their arteries, he put them on a lifestyle program, and he repeated their angiograms after 2 years. And when he repeated their angiograms, there was an average 20% reduction in narrowings. 70% became 50, 50 became 30. And then he did a deep dive, and he said, what is the cause of the reversal? Was it the diet? Was it the high-fiber vegetarian diet? They were devout Hindus, right? Was it the brisk walking every day? Or was it the meditation? And the only independent factor for reversal of heart disease was 40 minutes of something called Raj Yoga meditation per day. Now, how can you explain this? There is plausible mechanism here. We know, actually, 2 things. Chronic stress as a risk factor for heart disease, this is actually published in cardiology journals, is the same as being a smoker or having type 2 diabetes and high blood pressure as a risk factor. Odds ratio about twofold increased risk, all right? Most of us have got chronic stress, we're not managing it. 2, we know that chronic stress causes inflammation in the blood and increases clotting factors. This is a publication in The Lancet using MRI scanners looking at objective markers of stress, amygdala, subjective markers, and correlating it all. So what's really interesting, there's an evolutionary explanation for this. In the hunter-gatherer time, if you were, say, your life was under threat by, say, a saber-toothed tiger, all right, and you were running away, the body in acute stress increases clotting factors and markers of inflammation because it wants to reduce the risk of you bleeding to death. But the problem we've got now is we've got a lot of chronic low-grade stress, so this is actually almost like an adaptive whatever response. But heart disease is a chronic inflammatory process, so it makes sense. But it also makes sense that the other thing is heart disease is also dynamic, it's not fixed. These soft plaques that we think are fixed, you get a blockage and it gradually increases, they can regress. And I went to India, and this is also part of the, I'm going to show you a trailer of my new documentary soon. You can't see it very well because I had to see it to believe it. I was like, okay, is this study real? Is this... I couldn't believe what I saw. There were patients of this doctor. He's managed hundreds, maybe thousands of people, all of them coming to tell their stories. He was showing me the angiograms. Even the fact of seeing even a complete occlusion 2 years later opening up was extraordinary for me to see that, right? And he's clearly doing something. Now, of course, we need to be a bit more precise of exactly what's going on, what's doing it, how we need to optimize this. And I said to him, why have you not done a randomized control trial? And he said to me, I've done a randomized control trial. I couldn't get it published anywhere. And he said, one of the American, I can't remember whether it was American Heart Association, but a prestigious American cardiology association society came to Mount Abu. He's got this huge institution there, this hospital, this place where people learn Raja Yoga meditation, which, by the way, is not just meditation, it's a spiritual transformation. It's changing the way that people think, how they deal with anger, etc. And he said he presented the data to them, and they thought, this is really interesting. But he said, there's a problem. This is the feedback he got from them. It may ruin our stent business. And he's not got it published. He's in our documentary, though, which I'll show you the trailer for in a sec. So we know that stress and heart disease is a problem, but there's something bigger that we need to appreciate as well. And this is not... we keep hearing this thing about individual personal responsibility. We're all interconnected, but anyone who understands public health knows that actually a bulk, if not most of what determines our health, and estimates vary from 35 to 55%, is what we call socially determined. What does that mean? Social determinants of health, all right? This is Tom Friedman's health impact pyramid. So counseling and education has the least impact. Most of it, of course, environment is important, right? We're not going to solve the obesity epidemic unless we make the food environment healthier. But socioeconomic factors, what does that mean? It's actually biopsychosocial. And this is best defined as the conditions in which we are born, grow, live, work, and age, and the drivers of those conditions. And actually, all of it is rooted in psychological stress. So we know, for example, if you were a victim of severe psychological abuse as a child, or sexual abuse, that can knock off 10 to 20 years off your life expectancy, right? Epigenetics, chronic stress, etc. All right? And if you're, say, if you're a mother, now my mum actually, who died prematurely as well, my older brother had Down syndrome. If you are a mother of a disabled child, that also is a very stressful situation to be in. And there is some data done by Alyssa Epple that shows that actually that can also reduce life expectancy by 10 years. So this is a stress issue that's going on. And social inequality, and I think you're pretty good in the Netherlands, actually, compared to most countries. But the greater the gap between the rich and the poor, there's something called status anxiety. You're more likely to compare yourself to other people. It also reflects a more materialistic society. And that is actually a driver of chronic stress in the population. We're constantly comparing ourselves to other people because of image, wealth, status. So actually, there's a lot of literature out there. And this is a book called The Inner Level, basically explains how inequality affects us individually and alters how we think, feel, and behave, right? But of course, that's very interesting. And it's not that the social inequalities, if you look at the problems, right, I'll come on to that with the, and we're getting towards the end of the talk. I know it's getting late, but are you okay for me to go on a little bit longer, yeah? Yeah, okay, fine. You're not getting bored yet, good. So one of the other interesting things as well, we have to think about this when you think about jobs, because politicians talk about creating jobs, but we should be talking about what is the quality of those jobs. Are people being paid enough so they can lead a healthy life, right? Are they feeling valued? And Michael Marmot, who's a guru on social determinants of health, said, a poor quality or stressful job can be more damaging to health than being unemployed. So we shouldn't just make it simply about jobs and unemployment. It's about the quality of the job. A lot of these big corporations, they pay their production workers very small amount, like ridiculously low wages, right? And it's not right. So what is the other aspect of the bottom of the pyramid about the socioeconomic factors? So there's biopsychosocial and how that all interacts, but there's something called the commercial determinants of health. And now we're getting to the root cause of the major problem right now in society, all right? Commercial determinants of health and public health is defined by this. Listen carefully to this. Strategies and approaches adopted by the private sector, strategies, to promote products and choices that are harmful to health. So deliberate strategies that they, of course, what comes to mind, big tobacco straight away, that hid data on the harms of smoking for so long, right? Now you can't, this is quite a busy slide. How do big corporations exert power that ultimately affects our health, called the macrosocial determinants of health, and risk factors for disease, and then population health, and everything that we experience? And it's important to look at the bigger picture of this. So they have control or power over decision-making and control of the political agenda. Political environment. I know many MPs. When I was doing the campaign on the sugar tax and sugar drinks, MPs I spoke to, politicians, there were the Department of Health, I think this is 2012-13, there was evidence to show that they had to decide on obesity strategy, they had 99 meetings with members of the food and drink industry and 0 meetings with public health doctors. They think the information they are getting, think about this with a vaccine, right? They think it's complete. They think this is expert opinion from lobbyists as well, whether it's Big Pharma, Big Food, right? And this, of course, leads to other decisions. So there's lobbying, there are revolving doors, you have organizations within parliament committees that are loaded with people who represent industry. We'll come on to just exactly what industry are doing and their shortly. Preference shaping, capture of the media. They can control a narrative. They give us, Rob Rose said to me today when I met him, he said, people are given the illusion of choice. And he gave this really good example about where he asked his son, you've got a choice between having a pizza and a burger. What do you want? And he chose the burger. And he said, later on, did you feel you had a choice? Yeah, I had a choice. But there was no mention of real food. People are getting the illusion of choice, right? Philanthropic organizations, in the way that they also shape the narrative. The Bill and Melinda Gates Foundation. Heavily invested in McDonald's, Coca-Cola, and pharmaceutical industry stocks. Bill Gates has made almost $500 million, right, from investments in the COVID vaccines. Why is that a big problem? He's now the second largest funder to the World Health Organization. Margaret Chan, the former Director General of the World Health Organization, said 70% of the funding of the WHO comes with strings attached. I'm sorry, happy to debate anybody on this. I used to be a fan of the World Health Organization. I think they started off with good intentions. But right now, as long as they can take money from industry, they shouldn't be trusted on anything. They capture the knowledge environment. Most university research funding now comes from drug industry when it comes to trials, clinical trials. Didn't used to be like that in the 70s and 80s, okay? Most of it was publicly funded. Legal environment, limited liability, threat of litigation, right? We had this limited liability COVID vaccine. You can't produce a medical product, this genetic technology, whatever you call it, and rapidly produce it and say that we know it's definitely safe and effective, and simultaneously say that if any harm comes to members of the population, the drug industry can't be sued. How did we even allow that to happen? It's extraordinary, because most people didn't know this, all right? And then extra-legal environment, opposition fragmentation. If there are people, now it only takes a few people, if you look throughout history, and this gives us promise, honestly, even people here today, this is extraordinary. It only takes a few people to be dedicated to the truth and to get it out for it to really emerge and change things, okay? So what they do, they have this thing called opposition fragmentation. They want to keep that information suppressed, all right? This is power to avert conflict. They don't want conflict happening, right? They even don't want these hatchet jobs ideally because it actually, fuels the debate. Power to avert conflict, keep conflict hidden, okay? Conflicts between the interests of the powerful and those over whom power is exerted. The general population don't know what's happening, and they don't even know that they don't know. Just how bad are the drug industry? How bad are they, honestly? And how can we apply lessons from history? John Abramson, who has been involved in more litigation cases than any doctor in the world, in the United States, in a conversation with Joe Rogan, explained what happened during Vioxx. Very briefly, Vioxx was an anti-inflammatory drug, blockbuster drug, came out in the late 90s, and it was marketed on the claim that it was better than ibuprofen as a painkiller, but didn't give stomach side effects. Eventually, it was pulled in 2004 because data emerged that Merck, the drug company Merck, had hidden information suggesting that it actually was going to increase cardiovascular risk, ultimately responsible for the death of 60,000 Americans. All right? And they were fined close to $1 billion in 2011, but a small fraction, really, of the profits that they made. And during the discussion, the legal case, there was a exposure of emails, internal emails of Merck. The chief scientist of Merck said words to this effect in the internal emails when the drug was initially being pushed out. And the words were this. Essentially, he said, "It's a shame about the cardiovascular effect of this drug, but the drug will do well, and we will do well." What do you call that kind of behavior? Any thoughts, any descriptions? Yeah, fine. Psychopathic, probably. But before I give you that diagnosis on that behavior, or the best diagnosis to describe it, and this is really important because it's relevant to what happened with the COVID vaccine, in my view. In 2001, the FDA wrote to Merck saying that we have concerns about cardiovascular risk, and you have to put a black box warning on your packaging to say there is a risk, maybe a heart attack risk here, stroke risk. What did Merck do? Not only did they ignore the FDA's warning, they then doubled down on their marketing. They increased the marketing of the drug. They then put more reprints from the New England Journal of Medicine, right? The medical journals take money from industry. They take sometimes millions of pounds or dollars, right? And those reprints of the articles of those trials are then used as marketing material. So they wanted to produce as much of these papers, because as doctors we know that drug reps come or whatever else, or they give us, and we say, oh, it's published in The Lancet and has this very nice glossy paper, and we think, oh my God, this is a great scientific paper, etc. They wanted to produce as many papers to give to every single doctor in the United States. So they doubled down the marketing. The New England Journal of Medicine made probably hundreds of thousands or millions of dollars, and this then stalled the whole process. Think about that. They've been told, they know there's a problem, and they're now going to increase the marketing. And the way to describe this behavior has been diagnosed by forensic psychologist Robert Hare and Joel Buchanan in the book The Corporation. And I'm not talking about individuals here, because I think this is a system problem. The legal entity that is a big corporation actually fulfills all the criteria for psychopathy. All right? What does that mean? It means reckless disregard for the safety of others, deceitfulness, repeated lying and conning others for profit, incapacity to experience guilt. Does that sound familiar? Drug companies have a legal obligation to produce profit for their shareholders. They do not have a legal requirement to give you the best treatment. So something needs to change in the law to make sure, this doesn't happen again, or we actually improve the system. Now, I was getting very suspicious. When the mandate stuff was introduced, I thought to myself, hold on a minute, this doesn't make sense. Because by the summer of 2021, we knew that it wasn't stopping infection or transmission, and we knew there were serious harms. And I said the only people that are likely driving this and are going to benefit from this were Pfizer. And it recently got exposed by an investigative journalist in America that early in 2021, likely, I'll be honest with you here, Pfizer, they can try and sue me if they want. But you know what? I don't think they're going to try and sue me because I think this is true. Pfizer likely, when they knew this vaccine was causing serious harm, and wasn't having a significant effect on preventing infection, they then pushed for mandates for this. And they funded organizations, gave them thousands of dollars, tens of thousands of dollars, grassroots, credible organizations in the US to push the narrative that mandates were essential. This is completely and totally psychopathic. I was a witness in a court case in Finland a couple of months ago, and what was interesting about this court case where a business entrepreneur was suing the Finnish government for human rights violations because he did not have a COVID pass to get into a cafe. The chief scientist of Finland, who is the chief of the WHO SAGE Committee on Vaccines, Hanna Nohynek, under oath, said in December 2021, when all these mandates were being pushed everywhere, she said, and this is documented, right? She said, at that stage, the protection from infection from the vaccine was not 50% or 40%, zero. Zero. And she advised government, and she advised governments to say that mandates are actually not a very good idea. They're going to give people the illusion of protection. That was never acted upon. This is the real battle in healthcare that we've got, is one of truth versus money. Now, let's come to the present day. From everything you've heard of the talk so far, we now have something going on in the Netherlands, and everybody should be aware of it, all right? We had this success, finally, in a mainstream newspaper, featured on the front page, thanks to these Dutch researchers, Saskia Mostert, right? I think she deserves a round of applause for the work she's done. And she's a very good scientist and very careful. She's not saying that the COVID jab is definitely causing the excess deaths. She's looked at the data over the last few years, 3 million excess deaths in the Western world, all right, and correlated and said, listen, there is a link here that needs to be investigated, and it may be a cause of excess deaths. However, that's just one bit of data. For me, it's very, very clear. We have every bit of data possible that links this vaccine likely to be the primary driver of the excess deaths. Randomized control trial data, high-quality observational data, clinical data. We've got this data now as well. It's overwhelming. And the only reason, one of the main reasons why most people are still not accepting this, other than the big financial interest too, is willful blindness in my view. But this paper, and I've read it thoroughly, in detail, I think it's and it was peer-reviewed over a year, meticulously. She's under pressure. She's getting attacked. And I know there was a newspaper article, I think a few days ago, where the Princess Maxima Center is now trying to distance themselves from her, one of the most decorated or respected academics. Yeah, absolutely. Absolutely. And guess what? No. Right, absolutely. So, we have to, sunlight is a very potent disinfectant, right? What do we know about this center? It also, for many clinical trials, gets money from Pfizer, right? This is what's going on here behind the scenes, in my view. And today, in the Anderekrans, I was asked to give a quote, and I actually said, this center, the people in the center, they should be ashamed of themselves. And I said, anybody who is denying the clear evidence of a link, a substantial link between the COVID vaccine and excess deaths, is either incompetent, immoral, or both. So the root cause of the problem really is the economic system that has created these companies and given them excess power. You may find this quite shocking. This stuff started off in the 80s, the so-called neoliberal economic model, which was about giving corporations more power, more deregulation. Milton Friedman, who got the Nobel Prize in economics, all right, who's behind the current economic system we live in, he actually said this, and this is something even taught in business schools, I can assure you. You may find this shocking, but I'm going to tell you what it is. He said, it is immoral for big corporations to put people ahead of profits. Let me repeat that. It is immoral for big corporations to put people ahead of profits. This is the mindset and the culture that has been created. It's a dirty secret within the business world. So this is why we are where we are, and it's a complete disaster. What can we do about it? There are solutions here, okay? The triangle that moves a mountain. Mark Twain said, simplicity lies in truth often. Truth lies in simplicity. We create the relevant knowledge, disseminate the greater truth, okay? Have conversations, freedom of speech. We get to a greater truth through dialogue. We then get the social movement. People here today. That's great, right? Normally, one of the ways of disseminating the truth, ideally through mainstream media, but there's also social media now, and that's obviously having an uptick. So we create the social movement, and we need political involvement because politicians ultimately have controls over laws that can actually make a society fairer, right? 5 minutes, right. I've been given 5 minutes, and I'm actually on 5 minutes, so don't worry, I'm about to finish. So I'm actually literally the end, and you're about to see, by the way, I know the 2-minute trailer of the movie, 5 minutes, absolutely, I'm done. Listen, suffering is an inevitable part of life, okay? I've lost both my parents prematurely to failures in the system, both doctors. I lost my brother when I was young. I lost both my parents, 68, 73. And even my mum, she had an awful situation where because the hospital was so busy and they were so stretched and she was admitted with sepsis, they missed a heart attack, right? And she went to a coma from sepsis and she died. That became a front-page story to try to influence the last general election, because I said actually the Tory government, Conservative Party government, had been responsible for policies where they were complicit with these industries. Big Food and Big Pharma are enemies of democracy, right? And they've been enemies of democracy for a long time. And they tried to influence the election. Sadly, that didn't work at the time, but of course, you know, history, over time, things can change. Of course, you know the story of my father. For me, on a personal level, I don't feel like I'm a victim, but because suffering is an inevitable part of life, what we need to do is grow from that suffering. And powerful courage, compassion is powerful courage. What does that mean? You turn your own suffering so that you can help other people, all right? And I think that's the kind of philosophy we all have to think about. But that means coming back to basics of spirituality and ethics, right? Of all the virtues, courage is the most important, because without courage, you can't practice any other virtue consistently, right? Tyranny emerges when people are afraid to say what they think. Tyranny emerges when people are afraid to say what they think. And when you have something to say, silence is a lie. Silence is a lie when you have something to say. And when everybody lies on all the time, the tyranny is complete. Just think about this for a second. If we are not the best versions of ourselves, from an ethical point of view, if we don't speak the truth and speak out, more people will suffer and more people will die. But don't underestimate the power of your speech. There's a ripple effect here. Every one of you here, we can all change this system together if we act from a place of virtue. Knowledge without action is vanity. Action without knowledge is insanity. We've seen a lot of that during the pandemic. But wisdom without courage is fruitless. All right? So, thank you. Remember, rights are only won by those that make their voices heard. You're here today. Let's all keep shouting, making noise, and let's create a better future for ourselves and for our children. Thank you very much. Thank you.
Thank you. Thank you so much. Thank you so much. Yeah.